Hello and welcome to the UK NEQAS IIA webinar series, Mysteries of Myeloma. I'm Dina Patel, Scientific Director of UK NEQAS Immunology, Immunochemistry and Allergy, and I'm proud to introduce the fourth webinar in this series entitled New Monoclonal Gammopathy Patient, Now What? I'm sure you're all very familiar with Zoom, but just a few housekeeping rules before we start. So our speaker today will present their slides, followed by approximately 15 minutes question and answer session with our speaker panel. If we do run out of time today, any of the questions that are unanswered will be followed up at the session next week. So all the questions can be viewed by attendees here today. So if you think that a question is really important and you definitely want it to be answered, then please feel free to upvote the question by clicking on the thumbs up icon next to the question within the Q&A area. So the more the question is upvoted, the more likely it will be asked. So we won't be using the chat function today to answer any questions. So if you do have any questions, please ensure that you use the Q&A section. We are recording this webinar and we will be sending the links to the on-demand recording to all registered delegates in the next couple of weeks or so. Unfortunately, we're not able to award any CPD points as we can't verify attendance, but registration certificates will be emailed to you, and we suggest for CPD purposes, you could write a brief reflective statement on what you've learned from the session. So without further ado, I'm delighted to introduce our speaker today, Dr. Ross Sadler. Ross began his training at Oxford in 2006 and now works in the immunology department as a consultant healthcare scientist. Ross has been focusing on investigation care pathway processes since 2017, with the aim of creating laboratory investigation services rather than just simply testing services. So Ross, if you could please share your slides with us and then I'll hand over to you. Thanks.
Okay, thank you very much. And thank you everyone else for coming to join today. It's certainly, as a panelist who's been into all of these so far, it's been really touching to see just how many people are interested to learn about what we have to say. And we're always very keen to see the questions that come through. I wrote that biography that Dina wrote, just read out, was something that I'd forgotten had been said, or I planned to have said. So it's really good because it fits very well with what I'm going to talk about today. So I'm really glad that all corresponds. We're going to be talking about the next stage on what's been built from the previous episodes. And really the first part of what I want to bring up is this idea of a bit of an internal question to yourself or your team, or the service that it does the myeloma work in your hospital, depending on who you are in the process. And that question is, are you a testing service or are you a healthcare laboratory service? Because I think they're two very different things. And I think that one of them is something that's maybe a touch more shallow than what we really need at this point. And I highlight really more the idea of what is needed, and maybe the gap between what we have at the moment and what we need, because I think that we're underutilizing what laboratories can do in a care pathway. So throughout this talk, there's going to be constant reference back to this idea, because I want people to reflect, if anything, if the only thing you do from this particular part of the talk, from the whole series, is just reflect on what role your service has in a care pathway in general, but uses the myeloma pathway as one good example, then that would be for me a really useful thing. I want to go back over what has been said in the past. I think it's important for us to try and do that. So there's a couple of the principles that we've talked about so far that I want to try and bring through on here. So number one of these is that The opportunity to have a myeloma screen performed on a patient should be freely available in your service, and it should be available to all your clinical users, no matter where they come from, secondary or primary care. There shouldn't be any demand management on that myeloma screening service. That's not the same as the idea of trying to think about demand managing just having immunoglobulin levels measured, for instance. Immunoglobulin levels can be measured for other things that don't necessarily have to be part of a myeloma screen. You could ask me the question, well, how can you tell the difference between the two? Well, I'd like to put that back to you again and say, really, you should be trying to understand why someone is sending a sample in to have it tested in your service. That, again, is the difference between you just testing something when it turns up in your inbox and you actively engaging with a process about someone coming to you for a request for some help. And if you understand that someone wants to do a myeloma screen, then that is the moment when you should make sure that it is done. We should always make sure that we are educating and providing resource to all our service users to help guide them on when should they do a myeloma screen, when is it most appropriate. The most useful resource we have at this moment in time is the Myeloma UK GP diagnostic tool, which goes through these. I've just got one excerpt of it there, but it is available to be able to use, and it's very useful to be able to have to gauge whether it is required or not to have a myeloma screen. And it's about keeping it fresh in people's minds. I think we have to be very realistic and pragmatic about the idea that although myeloma may be one of the big 5 conditions that you may be involved in, from an immunology lab or a biochemistry lab that has an immunology focus, from a GP's perspective, they're going to be seeing patients coming in from a whole plethora of situations. And so making sure that they can notice the moment when this is right is not always easy for them. If a myeloma screen is going to be performed, it must include serum immunoglobulins and serum electrophoresis and one other investigation out of the following: urine electrophoresis or serum-free light chain analysis. Additional testing of biochemistry and hematology markers is also to be encouraged, and it's something that we can help with, and those should include serum creatinine, calcium levels, and full blood count. But what I want to bring up and talk about just briefly, because I've seen it in the questions that have come through as we've gone through the previous episodes, is about decisions about what that second assay should be. And it's very realistic that decisions on what second assay should be will be using factors of technology and cost, and I think cost more than anything. But I want to this is in my head how I visualize a lot of what goes on in myeloma services when I think about them. And that's this idea that if we take the whole patient cohort, that we could have significant patients being found via a comprehensive or complete myeloma screen. We suffer this problem where sometimes we can see a lot of attention, and I've seen the questions coming through on the chat where people have been very interested to try and understand, is it better to use urine electrophoresis or serum-free light chain? And I do liken it to a bit of a Pepsi Cola challenge. But actually alongside that, the actual difference we're talking about here is marginal compared to if we don't do a complete myeloma screen in the first place. And so a classic example of that was in my own service prior to about 2017. And that was that if someone sent in a serum and did a serum electrophoresis, if we didn't have a urine, our action was to put a comment on that said, you need to send a urine. And that was it. That was our involvement in that whole process at that moment. And that is not a complete myeloma screen. So therefore, you're now at the mercy of hoping that you will get compliance on that request to be able to complete the investigation that was originally asked for. Okay, so the underlying risks of incomplete investigation have to take priority over anything else about decision making, about when we're going to use whatever assay is available for us to use. Number 3 of our underlying principles is an idea that we need to have a clear criteria for results. So we need to understand and standardize within our practice what we're going to use as markers and metrics to decide if a patient has a monoclonal gammopathy or significantly indicating that they have a non-secretory myeloma potentially in there. So we need to understand, what are we going to take seriously, what are we not going to take seriously, and how are we going to take those forward. As it stands right here, right now, with current technology that's being used in the UK, and I emphasize in the UK because there are other parts of the world that are now starting to use a next generation of technology, a monoclonal gammopathy should be defined as a monoclonal protein that's identified and isotyped in serum or urine via electrophoresis, immunofixation, immunodisplacement, that technique to be able to determine it. Okay, so I use serum-free light chain in my service. I'm going to show you a little bit about the distribution of how we use these different things, urine and serum electrophoresis and serum-free light chain briefly. But what I've said it before, serum-free light chain can indicate monoclonality. It cannot confirm it, and it can very strongly indicate it in some cases, and it can less strongly indicate it in other cases. So we need to have our benchmark of what we will say has a clone in it, and in the current technology in the UK, that would be electrophoresis, immunofixation, immunodisplacement, and they're useful for us to be able to help isotype and identify. A lot of the time, we often make decisions of whether to use immunofixation or immunodisplacement, and the difference of whether you use one or the other really has to be put down to the competency and the confidence of the team that are performing it, rather than an arbitrary cutoff. I don't believe there is a magic number that says if you have a marker in the gamma or beta region of a certain amount, that suddenly means that you need to do it by immunodisplacement rather than immunofix, or vice versa. Can the team who are doing it on a daily basis reliably and accurately be able to find monoclonality? If they see that on a CZE, are they going to be able to pick it out confidently using an immunodisplacement method, or are they going to have to use immunofixation? And to be honest, if you can get to a point where you have a robust process that you can audit yourself and prove to yourself works, then go forth and use it. That's great. That's what we want. Non-secretory myeloma needs to be considered. It needs to be flagged. If you can't find a monoclonal protein, despite explicitly looking for it, but the patient still shows significantly skewed serum-free light chain ratios and relevant clinical symptoms that could be indicative of them having a non-secretory myeloma. So probably one of the most explicit ones will be the idea of having hypergammaglobulinemia. So if you've got a patient who's got a low IgG level, and quite a substantial low IgG level, and will have other CRAB symptoms, they've got a significant serum-free light chain ratio, but you can't find any monoclonality in the urine or the serum, then you need to seriously consider that this patient still could be significant. So, I'm very conscious that I've just preached about what I think you need to do, and I haven't really told you what I do. So I think I probably need to put this into context for you. So I'm happy to open this up and show you how we will run this as a myeloma screen. So when we accept that myeloma screen by anyone, we will accept two versions of a myeloma screen into the service. One of them is that they will do immunoglobulins and electrophoresis, and they will send a urine. We will accept that as a myeloma screen. And if we find it normal / we find no monoclonal protein findings, then we report it. If we find a monoclonal protein, or we see no monoclonal protein and low immunoglobulins in a suitable individual, then we will carry on and do serum-free light chain as a follow-up test. So we will do the third test. The other way round is that someone can request from the outset immunoglobulins, electrophoresis, and serum-free light chains. And again, if we find a monoclonal protein, or we see significantly skewed serum-free light chain ratios, then we will follow up the urine electrophoresis, because again, we do not think that the serum-free light chain ratio is enough to confirm. It can strongly indicate, it can mildly indicate, it can very gently indicate, but ultimately we need that urine to follow it up. I'm very honest here. Here is our data from last month. So you can see here the activity of what we've done. So you can see that we use all of them. And we use all of them enough. It's not anything, none of them are a token effort. What do we do? What do we endeavor to do as part of a healthcare laboratory service? And from what of that I mean is, if we have a clearly indicated initial request that needs a myeloma screen, but we only receive immunoglobulins and electrophoresis, and that's it, then we will add the serum-free light chains onto that serum sample. That's a change that we made because of this reason over here that you can see. that compliance with proactive guidance in Oxfordshire for supplying urine for electrophoresis from the outset for a myeloma screen only ever yields us 40% compliance. We even did a second audit where we explicitly gave them a second piece of guidance on the serum result to say, now you send us a urine, and we followed that up. And when we did that, our total compliance in the whole thing only then went up to 50%. So no matter how hard we tried, we were still only getting 50% of the urines that we felt we needed. And that's one of the reasons why we felt we had to do more than just test what was sent. And again, as I said, this is bringing back the idea of what are you here to do? You can see the algorithm still runs through the same idea that says, once you've got 2 of your tests working, you may do the third if you have something significant from the first 2. And again, this way round here, if I can see that it goes through to urine. Okay, so this one here is a bit different. This is saying if we know that they're asking for a myeloma screen and they haven't sent us a urine, and in this one, it's that we have an initial request, but they haven't said they want a myeloma screen, but they have given us clinical details and a patient location that indicates that the patient could have myeloma or could be having amyloidosis. So what do I mean by that? Any patients that have an immunoglobulins and electrophoresis sent in who come from trauma, anyone with a clinical detail of neck of femur fracture, anyone who has cardiac heart failure and is asking for immunoglobulins and electrophoresis, because I don't really know of any other reasons why you would ask for an immunoglobulin and electrophoresis in a cardiac patient, to be honest, without you wanting to think about cardiac amyloidosis. Any patient that's coming in with acute kidney injury, we're going to sit there and assume, and we're going to take that motion and we're going to justify adding on an additional test at that time so that we can get a myeloma screen completed, because we don't have explicit instructions that it is. Now, there is absolutely, I fully back anyone who says you need to build an IT solution in here that allows better communication with an EPR system, whether that be a GP order com system or a hospital electronic patient requesting system. That means you can press a button and say, help me rule out myeloma. I'm 100% behind that. The reality is you're still going to end up with some patients who you will not get all the samples for. And I can give a few examples where I've heard other talks by senior members of the Royal College and NHS England who have expressly turned up and said about their frustration about having to have an elderly relative try to produce urine for a urine electrophoresis and getting very frustrated. And that's them as a relative, not as a healthcare professional. So we have to be realistic that we're not always going to get what we want on the day, and we might have to take matters into our own hands to help achieve the outcome that was originally requested of us. There are a few other permutations you can get, and one of those is going to be that we just get samples being sent in if we are the primary supplier of myeloma screening for a requester. By that I mean you may have a DGH, if you're a bigger lab, you may have a DGH send in serum-free light chains for you because you supply that, but you know that they have a myeloma screening service back in their resident lab. If that's the case, you are not their primary supplier of myeloma screening. But if you do get a sample from someone and you are their primary supplier and it's only asking for serum-free light chains, that's not sufficient. And so you will add on the immunoglobulins and electrophoresis to that sample again to follow it through. And although it's very rare, it does happen. Sometimes you will get a sample coming in and it's only asking for urine. You've only got a urine, asking for urine electrophoresis with no serum coming at all. And again, you need to get that serum. Now, you can't do any more than ask for it. So in that particular instance, so that's the worst situation to have. And in that case, we will ask and we will do the immunoglobulins and electrophoresis as a first line. And then if we feel needed, we will have the serum-free light chains. So in all of these cases, we're trying to get the most efficient 2 tests we possibly can to complete the myeloma screen, but are prepared to use the third one as and when is necessary. So let's talk about what I think can sometimes be seen as an elephant in the room on this, which is about serum-free light chain usage, cost, demand optimization. So I've shown this before to people. So it's just a very simple way of being able to think about how we have to weigh up the usage of this assay in a myeloma screening process. And the reality is down here, we've got the smallest number of patients that we're going to be testing. And in some ways, we've got the best financial health economic justification for doing it. Okay. And as we go further up to this top bit, we've got this idea of doing mass screening of entire populations and screening proactively into all members of a population above a certain age, and using this to be able to pick up earlier aberrancy. And it becomes much, much harder to produce financial viability from health economics to be able to say that that's worthwhile doing. But there is a middle ground. And so really, I guess this is one of the things that, again, a take-home message. I believe that whilst it's not necessarily beneficial to actively seek out all possible monoclonal proteins that could be found in a population, if you are asked to do some investigations, you should do them. And all aberrant results that you do find, and all identified monoclonal proteins that you do find, they should be treated seriously and with appropriate clinical consideration. And that, for me, is a big thing that I think there's a group of us take maybe for granted, but unfortunately I am acutely aware out there in the community and in periods of history, that has not always been the thought process. There has been a thought process in the past that has said, actually, we don't really want to bring these up because, you know, confronting it will cause more anxiety and logistical hassle than actually having to deal with it. So how can we try and use different strategies to try and gain utility or maximize utility from a situation where we can sometimes get bogged down in creating maybe too many aberrant results? So one of the things I think is very fair to say about serum-free light chain as an assay is it is very sensitive, and that can be very good and useful about it. The problem can be about it, and it has been raised before, is that it can produce complex interpretations, and it can produce what I guess in the most simplistic way we could say are false positives. That's a very rudimentary way of interpreting it, but let's say it's going to produce results that will initially flag, and most likely because they're going to have a mildly skewed kappa-lambda ratio, which could indicate monoclonality in your patient, but it's not so strong that it's not absolutely given. So how can we use strategies to do that? So one of the ways we can do that, and one of the ways we've tried to do that in our group, is to try and make sure that we've got something that is the most appropriate reference ranges that we can build. And this is an example of some of the work we've done to create age-specific reference ranges using large data. So taking large bodies of data and using normality plotting strategies to be able to pull out normally distributed sections of that data and then move through and do 2.5 and 97.5 percentiles on it. And that's allowed us to be able to look and show that kappa-lambda ratios do change across age. And actually we see this bimodal split, certainly around the kappa end of the ratio. And as you get older, you start to see this. And it's not only with age that we see it, we also see it with renal function, which is linked with age also. And in our publication, we also talked about looking at EGFR scores and being able to make good definitions of when and how you might change your serum-free light chain ratio reference range, depending on what the patient looks like at that time. And that will help stratify and decide whether a serum-free light chain result that has been generated needs any further investigation. One of the pieces of work that we did around this was following up when we did create aberrant serum-free light chain results, and to say, well, what do we do with these? And we actually did a piece of work where we tried to determine where and how and when was the value of going back and fixing the initial CZE result that appeared normal, to look and see if immunofixation as a higher sensitivity method will be able to detect monoclonality. And we did find that that showed an interesting fraction in the osteoporosis patients. So patients who were showing evidence of fragility fractures, showing evidence of problems with osteoporosis, and we know that this group can have an enriched prevalence of myeloma within it. We found that we did see significantly higher amounts of immunofix only patients with immunofix only monoclonals found in them, and they were usually lambda as well, so IgG lambda and IgM lambda, which went quite against what we were seeing in other situations. So we've gone through a phase, certainly in Oxford, where we have done a lot of work to try and create a very proactive, high sensitive monoclonal gammopathy screening service. And one of the things about that is you sit there in your lab and you're creating these ripples in the pond of healthcare by doing your exciting activities. And that's very much what you have to think about, is what you consider to be something that creates a minor change in your part of the pathway can suddenly have huge ramifications somewhere else in the healthcare pathway. And that was one of the things that came out of this, because we started to generate very large numbers of patients with monoclonality who didn't look like they were particularly serious, but we had found them because we had looked a bit harder and we'd managed to identify them. And then primary care started to get a little bit upset about that, because they were starting to realize that all these patients were being generated and now they were there. What were we going to do about this? And I'm completely with them. And one of the things we have to be very careful about, again, coming from this idea of us being a laboratory healthcare service, is that generating accurate data on a sample is actually the bare minimum really to be done. We need to be able to understand and contribute to the next steps of that management for that patient. And doing that is actually as important as generating the data in the first place. So I liken this because one of the things I often say, this actually got me a quote in a NHS Leadership Academy brochure once, is that I often say to people that, you know, every single tube you see is effectively a patient. So that's what you're seeing. So don't think of them as blood tubes, think of them as patients, and that's who you're dealing with. And that's how you can make yourself feel like you are patient facing in that sense. And we often have this track system in large biochemistry labs, which for me as an immunologist and a bit yokel in that sense, still think it looks a bit like a yo sushi bar. But we have these tracks with these tubes. And actually one thing that we have to not visualize is the idea that actually these are patients going along on a conveyor belt. And once we've generated the data, that's it, they're gone. They just fall off the end of that conveyor belt for us. We don't think about them anymore. And there's nothing else for us to do. That's a very scary thought, and it's a thought that I do not want to be part of. So we need to think about all those patients that are processed through a myeloma screen. They need to have an outcome. They do have an outcome. And the vast majority of them are going to show no evidence of monoclonality, loads of them. And that means from the perspective of a myeloma screen pathway, they can now exit. Doesn't mean they can never come back again. They should be able to re-enter it if new symptoms, relevant symptoms develop in the patient, or if existing symptoms significantly progress and a suitable interval of time has elapsed. So we are within our rights to, you know, use science to be able to say it is unlikely, you know, that you measured it 3 days ago and you've come back again and the patient said that their back's now starting to hurt and you've measured it again and expecting to find suddenly a 30-gram IgG. That's going to be unlikely. So we can use science in this, but we can't shut the door on that patient forever and say, well, you've had your test now, that's it for the next 40 years. You know, you don't need to come down our way again. Don't darken our door. That's not an option. So we need to think about this idea of when and how can people exit the pathway and stay in the pathway and come back into the pathway. When patients do show monoclonality, we then need to get to the next stage, which is understanding how are we going to deal with that? How are we going to risk stratify what we do with them? Because unfortunately, what we can't do is think that we can treat all of them the same. And it is very much this idea of clinical responsibility. And that's where, from my own experience, conversations very quickly go is who is going to hold the responsibility for taking this patient into the next stage? I want to highlight this over here because this is the Myeloma UK, again, the GP diagnostic tool. And this is part of the work that Fenella and Joe and myself and others have worked on, is creating a set of instructions and guidance that can be used in primary care for when these results come back. Okay, so we see this guidance as a resource that can be used and utilized. I don't want it for everyone to feel that this is all they do, that they say they've done this and then they send this in the letterbox, give it to a GP and go, yep, that's my job done then, and walk away. That's not at all what this is designed for. This is designed to help our community and help us to be able to do what we need to do. And the data in there is sound. And it comes back again to what I said. laboratory healthcare professionals, I think, sit at the moment in a bit of a weird place, because we request a lot of the NHS system that we be taken seriously by the parts of the healthcare system, that we get the recognition that we need, particularly from patient-facing areas. But we're going to struggle to do that if we're not prepared to significantly contribute or take responsibility for the steps in patient management. And that's how I sometimes think we go around and throw ourselves around. I've seen people do this thing where they shout at people basically in meetings and say, look how qualified I am. I'm super clever. I'm amazing. And actually the reality is it turns very quickly into this, when suddenly it's, oh, well, actually, hang on a minute, how much responsibility are you willing to take for the patient? And that's what we have to make sure we don't do. And I don't really want us to do that. So let's talk about ideals versus real worlds about what we're going to do with these patients with monoclonality. So I've color coded it for you there, but basically what we have is a situation where in the ideal world, all patients with a new monoclonal protein would benefit from hematological input. 100% true. I can't see anyone arguing with that. It would be great if every time we found a new monoclonal patient, we could set up a process that said, you're going to go and have a 20-minute consultation with a hematology consultant, and potentially get all the consequential follow-up testing that might need to be done to give you a full workup. What's the reality? Hematology and those support services such as imaging could never be resourced to be able to achieve this. It's not going to happen. Another idea is this idea that says that monoclonal Gammopathy patients could be solely controlled by primary care. And as long as the GPs were educated and we trained them enough and we gave them enough resource and we made them focused enough on blood cancer, and we stopped them thinking about things like heart failure and bowel cancer and all these other things that, you know, obviously have hardly any prevalence. And so that they will always review the evidence produced from a myeloma screen investigation themselves. They'll get it all through on an order comm system, and then they'll always make the right decision. Again, that would be brilliant. But actually, if you talk to GPs and you sit and get their perspective on it, GPs are genuinely concerned about their patients' well-being. And a lot of their anxiety comes from the idea that they don't feel equipped in knowledge. They don't feel they have enough time to be able to get the CPD in, to be able to learn enough about this area, because whether we like it or not, this is a little bit niche. And they need to be able to have that time and the resource. They also don't have resource. So I'm going to highlight again in a minute. IT is a particular issue for them. And for them to be able to care for the patients properly, they feel they need these things. They don't have these things. And therefore we start to see patients slip through the cracks. And that's where the problems really start. So why am I even talking about MGUS or MGUS patients in the first place? What is it that's driving me to do this for you? And what is there about what's changing out there? There have been some big data work, multiple publications that have shown that if you have MGUS as a human being, you are going to have probably a poor or significantly poorer outcome than a human being of the same age and same gender and same demographic who doesn't have a monoclonal protein. Okay, now that doesn't mean that you're all going to die of myeloma. We know that the risk of progression to myeloma comes from well-established data sets which show the 1% per year, okay? And we're very aware of that. But what we are starting to see and what we're trying to put together now is the idea of what other comorbidities are patients with MGUS going to suffer. And we know that there are things such as increased risk of infection-related death, there is increased risk of thrombotic death, there is increased risk of organ failure, there is increased risk of fractures. And the ramifications of having a fracture as an elderly individual are not insubstantial. Things like infection prevention related deaths or healthcare associated acquired infections are all linked with having to go into hospital for emergency surgery. And across a certain age, that makes things very tenuous for you. And that can be linked to you having an MGUS, because you're 4 times more likely to suffer from a fracture if you have a monoclonal protein as well as osteoporosis. So we know that the MGUS has more ramifications for an individual than simply progression to myeloma. And so my personal philosophy is knowing that someone has MGUS is of more value than not. We need to continue to work out how we can maximize that fact that we have that knowledge, and that's where we need to keep working. Now, we've been working on this in Oxford since about 2017. And we've been slowly developing and building this. And our work so far is showing really consistent data that across a year now, we will find 1,000 new patients every year with a new monoclonal gammopathy. So we will find a patient with a new monoclonal band in their serum electrophoresis or urine electrophoresis. 20% of those will show data at the time of that discovery. That means we will contact that requester explicitly to inform them that the patient needs to be referred to hematology for review via a 2-week wait referral at least. So there will be some where we will ring them up and say, we'd really like you to have a conversation with hematology in the next hour, because actually we have a feeling hematology are going to ask you to get that patient in sooner. 65% of the patients that we find across a year will fall into that lowest risk category. They will be patients who will have a monoclonal protein, but we will really see no other evidence of anything, and it will be, effectively incidental. Now, those patients do not need to go to hematology. They still need to be in the system, however. Okay, so there is a limit to what they will get from going to hematology. And so one of the things I guess also want people to realize is you have got to, if you don't already, you need to engage with what do your hematologists actually do if a patient is sent to them who has a lower risk monoclonal protein. How much are they going to do extra to what we could maybe do not in a secondary care system? And that's where we need to start pulling it apart, because I don't know how everyone else feels about their cities or where their hospitals are based, but I can tell you now in Oxford, there is nothing good or fun about being over the age of 70 and having to try and drive across through the city of Oxford, get stuck in traffic for an hour and a half, find a parking space, go and wait for 2 hours to get through your outpatient clinic appointment, to go in and do all this work. It's nothing to gain for anyone to go and see that process if it's not needed. So I'm going to present here parts of our possible solution. I'm not saying this is the only solution. I'm saying this is the solution that we have set up. And so far, touching wood here, it works. It's doing what we set it out to do. And so what we are doing is we run a collaborative service. We run that collaboration with clinical hematology and with the Oxfordshire GP surgery cohort. And we have one clear aim in this, okay? So to have every patient who's identified with monoclonal gammopathy placed in a clear care pathway that gives considered and appropriate care relative to the presenting data that the patient has. And what I've put up on this screen is effectively how we split them apart. It's along the same format as what we have in that GP diagnostic tool. We put them into 3 scores of outcome. We have outcome 3, which are where we have patients who we consider them needing to go to see the hematology consultant. And we're going to go through and request that 2-week wait referral at least, okay? The reality is some of those patients will go in and it will actually turn out that those initial results are not that serious, and the patient is not going to have anything more than to be held in a monitoring cycle. But that cycle is going to be held within secondary care, and the hematology team is going to take responsibility for that. Or the patient may be fully diagnosed as having a myeloma and is going to go forward and go through treatments processes. The other extreme of that is outcome 1, where we have these low risks. What we do with this is that we're going to place them onto a database, a low risk MGUS database, and we're going to put them in for periodic monitoring. That patient will be notified when they're going to have their monitoring bloods taken. They will get those taken and they will be reviewed. And then from that, most likely, they will continue to remain back on the low risk MGUS database. We expect the vast number to do that. But there is always the option that they will progress, and that will be picked up and taken through. We have the middle ground, as you always probably need to have in life, and that is the patients who show metrics which sit roughly in the middle of severity. And in those there, what will tend to happen is that those patients will go through, and we have a nurse-led clinic, a hematology nurse-led clinic, which again, I work incredibly closely with, so that we can get notified that those patients exist and they can go into this holding pattern here. And they may stay in that nurse clinic for 6 months before moving one way or the other, or they may go straight onto outcome 3, or they may go straight to outcome 1. but it means that a patient is always somewhere. They're always located. They always have a position in this process at all times. And technically, you can always find them and you know what's going to happen to them. They haven't been lost. And if I tell you that, again, some of the work we've done, we looked at some data we did in 2014, because we now have obviously 6-7 years follow-up on those patients, of every patient we found in 2014, who we then had risk stratified according to these criteria. And looking at the ones that were outcome 1, the ones that hadn't died and during that time period, it was about 30 to 50% of them had ever been tested again for serum electrophoresis. So that's quite scary to think that at least 50% of them for the last 7 years have never been followed up. And that's pretty much why we felt that we needed to try and work on this. So all the patients that are in outcome 1 are under the care of their GP. So if we talk about it from a clinical responsibility point of view, the GP is maintaining as their clinical caregiver. They will go to their GP if they have any health concerns, symptoms, just as they normally would. But the difference is that the laboratory service is supporting those GPs. We are trying to help them with those things that they're struggling with. We're going to manage that risk stratification for them. They struggle to interpret the data that comes out of these. It's been highlighted in the previous episodes. Things like serum-free light chains are not easy to do if you don't do them a lot. And so we will take that. We do that risk stratification for them. From my personal perspective, we should be doing this anyway. It's part of our job to interpret the data that we generate. So that's how we work. We also help coordinate what is this condition and how the new care pathway will work, how those 2 questions are communicated, or the answers to those 2 questions are communicated to the patient. And that involves us setting up a time course. Once the patient is placed onto outcome 1, we have a time course that runs through for every patient, where letters are sent at certain times and instructions to the GP about giving them enough time to be able to call the patient in and have a conversation with them before a letter will turn up from the pathway, which they won't be expecting. So we work together with them to try and synchronize timings to make sure that the patient at all times is not being bombarded with information, but likewise left in the dark. We schedule the patient's going to get monitoring bloods taken. And we also, when the monitoring bloods are taken, we interpret those monitoring bloods and communicate the outcomes to the GP and the patient. So who have we used to help design this pathway? So we've got these 3 areas here, I said: laboratory immunology, clinical hematology, the CCG, the LMC, and the GPs all make one particular group representing primary care. And this other small inconsequential group, obviously I'm completely joking, the existing myeloma and MGUS patients. They're the groups that we were also interested in talking to about this. And so the design of all our letters used in this service to welcome the patients to the pathway, or to highlight that it's time for the monitoring blood, and the actual pathway structure itself was discussed with existing patients in the service. And I guess the thematic responses that came from these patients that really resonated with me was 2 things. One, they all talked about that moment they were told, particularly the MGUS patients were told they had MGUS. And they said that in each case, their GP had effectively gone with a strategy that said, if I talk with you less, if I spend less time giving you any time about this, I will be able to convey to you how insignificant it is and how little you have to worry about it. So I'm also going to just open the door a crack, go, you've got MGUS, and then shut the door again and walk away. And they said it never did anything else but create more anxiety for them, because it was like the GP just was avoiding telling them something. So it just made them worry. The other thing that they said when we talked about this idea of being monitored and how would they feel about this idea, they're going to get a letter that says you have a condition that could progress to something else, you know, and the worry around that. Part of what they said was they would have peace of mind that there was a system in place that would be taking care of their monitoring, and most importantly, reacting on their behalf as necessary. And that's the bit that they most wanted to know. There was security there, that something was going to happen, and that they didn't have to worry, what about if I've been forgotten about and something is going on inside me and no one's going to tell? And they were important things for me to learn about. We help the GPs. One of the things we do with the GPs is we've set up a process of a web link that we send them all to. We understand GPs are busy, so we have a checklist at the very top that just says, do these things. Inform the patient they have low risk MGUS. collect new bloods and urines for any outstanding biochemical results that we may not have at the moment, because you may not have done a complete biochemistry hematology process at the beginning. Be prepared. The patient could come in before their monitoring period because they may have new symptoms, okay, and they require testing on a new myeloma screen, and that the patient will attend the surgery for bloods to have their designated monitoring times done. And if they could click on any of these, it takes them to more information. So just an example, when they click on the first one, inform the patient they have low risk MGUS, it brings up these instructions, because again, one of the questions I certainly get quite a lot is, how should I tell the patient about this? What do I need to think about when I tell them? And again, we haven't reinvented the wheel here. We have used the standard information. This is information that comes in. Myeloma UK have this information available on their website. And we have our own nhs.net account, and we invite all people to write emails into us so that we can help them with queries and help understand it. What obstacles are you going to have in your process against you? I'm going to tell you now, it's going to be IT is the biggest one. Okay, and I put this maybe as a political statement more than anything, but that is how I feel sometimes when I'm working in the NHS at this moment. And this quote, I don't know who it's from, but I think they're a genius. And it's true. The gap between what is possible to do with IT and what the NHS can do with IT is widening every 6 months. And if we do not fix this, being able to do this next level of care is just going to get harder and harder and harder. Nothing fatigues me more than having to sit there constantly and hear the same thing that says, we don't have enough people to be able to do it. We don't think that this computer system can talk to that computer system, so someone has to take the information, write it down or print it out or take a picture of it and then retype it back in. All of those conversations tire me, and I just find this whole thing ridiculous. And maybe that's very short-sighted of me, but I really live in hope that we will start to realize that this is a secret to success if we can put more investment in this. We have had to think about that. And so how are we making progress? We have a consistent communication stream between the clinical hematology referral process and the laboratory output. Really, they're linked. They're one thing follows the next. So anything you create in your laboratory output, you should be able to know which bits should have been sent to clinical hematology for referral and which shouldn't. And I know I've heard so many stories in the last couple of years from different parts of the country where I've heard that hematology services are on their knees from unnecessary referrals coming into their service that they desperately want to try and be able to control in a fruitful and sensible way. The laboratory is the key to this, because the laboratory is the entity that finds the patient. That's the beginning of the process. We identify a patient with monoclonal protein. So it's imperative that these two systems talk to each other so that we can design and refine how that's going to move through and audit it. If you find rogue entities in your healthcare system that do not listen to the advice and just refer anyway, target them proactively, progressively. Talk about how to educate them and get a dialogue going, but don't just leave it and gossip about it. It's not going to help. We are prepared to modify our procedures if we think it's required, and iterative thinking is essential for something like this. You cannot get it perfect first time. You'll never do it. I heard a story the other day of a group who want to do a similar idea in another disease cohort, and they've gone through and tried to design the most perfect system that's fully automated. A human being never looks at it. It's been costed at £55,000, and it's going to take a year to even think about coding it. That is just not an approach that's going to work in the current climate. You have to go down a way of thinking about how can we build this and get it working safely, but can be ready to improve. And for that route, we have set up our own IT systems. We've started using other pieces of software that's out there. That this is, again, a sad state of affairs. There are entities out there and software out there that are used in industry and used by public and private individuals to be able to task manage, project manage systems, to be able to move things through pipelines of workflow. And this is an example of what we have. We have an online form for a new outcome 1 NGUS. So whenever one of our doctors is working, and if they're doing remote authorizing on a laptop at 8 p.m. at night, and they need to highlight they found a new patient that fits the outcome 1 stratification, they can go onto Google, they can fill in this, it doesn't break any patient confidentiality problems for us, and they put it in, and it will go into a tracking system that allows hematology individuals to see it. immunology individuals to see it and put that patient through a project process that means that they're going to get inducted onto the MGUS database, their letters will be scheduled. And I can't do this in my current hospital system. So that's why we've had to build new ways of doing it. Okay, thank you so much for listening to my talk. I hope that it has been what I sold it as at the start. I hope so. If it hasn't, I apologize. But I have some key things I want you to think about. Healthcare laboratory services, we remain in a pivotal position in care pathways. We are the start of the myeloma pathway. We find the patient. We have always been there. We just haven't always realized the potential that we hold. Patients do not get tests. They enter investigational care pathways where performing tests on their samples helps decide what the next stage in that pathway will to be. We have a duty to play a role in ensuring that and make sure that the correct decisions are made for the care of the patient. We can do that in lots of ways, in that empowering our users, educating our users, talking to our users, interpreting results on their behalf, lots of things. Myeloma screening is one of the most significant services that an immunology service will provide. And so it should be one of the most successfully standardized, okay? I don't think it is at this moment, but we're trying really hard to get us there. We need to have clear priorities placed on ensuring that comprehensive testing is performed and not worry so much about the nuance of the techniques that are used to do that. Every result has an outcome. A new monoclonal gammopathy result should be risk stratified, and a patient only remaining in secondary care if truly required. But if it is, then it should be. Lower risk patients are exactly that. They're patients with lower risk, not absent risk. Understanding what should be included in the concept of what risk is ongoing is something that we need to keep working on. And we need to understand of what breadth of the population needs to be placed through a myeloma screen. 3 years ago, I was getting no patients with heart failure. Now I get about 100 every 3 months. And we're finding patients with cardiac amyloidosis as a result of it. So there are entities in your hospital that probably still aren't engaging, and they should be. Ultimately, talk to your service users and make them collaborators and use that to work towards helping your patients. Thanks.
Ross, thank you so much. I'm sure everyone will agree that that was a superb and very thought-provoking talk. If you're very passionate about the subject as well, which is lovely to see. My thanks goes out to our speaker today, Dr. Ross Sadler, and to everyone at UK NEQAS who are making this series of webinars happen, and especially to everyone for taking time out to join us today. I hope you found the sessions interesting and beneficial. And we do have one more session in the series of 5 webinars. So you'll see the details of the remaining session next week. And in this final webinar, we will be joined by our panel of experts who will help us bring together all the information that's been discussed over the past 4 weeks. We will summarise and reflect on our learning, and this session will also allow discussion around various cases that have been submitted by the audience. The session is now open for registration, so if you've not already registered, you can do so straight after this session. UK NEQAS is active on all the social media sites, so if you do social media, we'd encourage you to seek us out and follow us to keep up to date with all the various educational events that we're putting on. And finally, once we've closed this session, please do take a few moments to respond to the short feedback survey, because we do use your views and opinions to ensure that any future training events are improved. So without further ado, thank you all once again. I hope you found today's session useful, and we look forward to you all being able to join us next week at the same time for our final webinar. Until then, stay safe. Thank you.